Thank you for giving us an opportunity to present our work done at Torbay Hospital. There are no disclosures to make. Literature abounds with confusion regarding the use of PRP in elbow tendinitis, ranging from good or to even suggesting strong evidence against PRP. Over a period of 6 years, we have injected over 300 elbows and we wanted to share our experience. The headlines from our study are: surgery was not necessary in over 95% of patients. PRP worked very well after failed surgery. Just over 60% were discharged with a single injection, and less than 22% of patients returned back after discharge. We offered PRP only to patients who had failed to improve after 6 months of conservative treatment and were ready to consider surgery. Our assessment included ultrasound scan and collecting quick dash score. A minimal clinically important difference, MCID of 15 points, and patient's own subjective feeling was necessary for discharge. We present our outcome of 265 sites in 230 patients with minimum 1 year follow-up. There were a total of 117 males and 148 females. 218 had tennis elbow and 47 had golfers. 11 patients were referred after failed surgery. 178 had single injection and rest had more than 1 injections. Minimum follow-up was for 1 year. Here is a summary of outcome with breakup of subgroups based on the initial presentation quick dash score. Overall, a statistically significant MCID drop of 15 points or more with a very good effect size was achieved. Effect size calculator suggested that with the use of PRP, overall there was a minimum 80% probability of significant improvement. There was statistically significant improvement with a very large effect size in all Q-dash scores except when the starting score was lower than 25. Even within this group, about half of them were discharged as they subjectively improved. Almost all complained of exacerbation of pain and compared it to their previous steroid injection experience. There was a lag in pain relief, but the benefit was sustained. Bruising was a common side effect. In this series, there were no reported infections. 11 sites failed to improve and required surgery. In one patient, we got the diagnosis wrong. It was a work-related injury with bilateral posterior interosseous nerve lesion. In 8 patients, the score worsened, but they continued with further PRP injection. 5 patients returned back after discharge and were treated with further PRP injections. The 5 tips we can give you are: choose a system that gives you high concentration of active undegranulated platelets. Use of ultrasound to inject sonologically abnormal area. Use of a large bore needle with shorter length. Using wrist splint to take the tension off the tendon insertion and to encourage healing by not using anti-inflammatories. A good centrifuge with slow deceleration and zero braking is important to get active platelets. The International Olympic Committee consensus paper compared different PRP harvest systems. Only 4 systems provided a very high concentration of active platelets, and in that paper, Exactech system was called as Genesis. It is important that the injection is carried out under ultrasound guidance. Subjective localization of the epicenter of the pain is unreliable. Neovascularization simply indicates that the body is attempting to heal. Target should always be area where there is collagen bundle disarray, and triangulation can be challenging as one will be using a needle with a shorter length. As PRP injection is considered to be painful, many clinicians choose a needle with a smaller bow. But injecting a viscous blood through this will require a lot of pressure and a slower rate of injection, giving excessive pain. As per Poiseuille's law, the rate of flow increases to the 4th power of the radius, and having a shorter needle decreases the pressure 8 times. I now routinely use 1-inch long 8-inch G needle whose inner diameter is 0.84 mm. Hence I use local anesthesia. It is wise to functionally offload tendons from excessive strain during healing. Many patients wake up in the middle of the night with the elbow pain due to the natural tendency to palmar flex the wrist, thus stretching the ECRB. Wrist braces do sufficiently take this tension off. Healing occurs with inflammation, and therefore it is counterintuitive to use anti-inflammatories or steroids. They may decrease pain but may not really promote healing. This may be the reason why many studies have shown steroid injections do not work long term. There are some limitations in our study. This is a case series and not a randomized controlled trial. We were not able to have full data set for 28 cases. We did not have access to any statistical help, and all the statistical calculations were done using free software available on the internet. We believe that the chronic elbow tendinitis is a continuum with progressive changes in presentation, ultrasound findings, and histopathological changes. Various treatments become available as the condition worsens, but 80 to 90% get better with non-operative management. Surgery should always be reserved as a last resort. With the appropriate use of PRP injections, we may be able to decrease the need for surgery even more and avoid the cost, burden, and the risks. Use of a decision aid like Torbay chart will help in this shared decision making. Thank you once again for the opportunity to share our work.